So Dr. Aphinyanaphongs is a physician scientist at Center for Healthcare Innovation and Delivery Science at NYU Langone. He's the Director of Operations, Data Science, and Machine Learning at NYU Langone. And he leads a predictive analytics unit, which is a very active unit full of data scientists, engineers, and clinicians focusing on building, benchmarking, deploying, and evaluating machine learning models. And we are super excited to have you give us your presentation today, and take it from here.
Good. All right, there we go. I'm not muted anymore. Yeah, thanks for that introduction, Narges. Yeah, so I just wanted to show a little results from the poll. Hopefully my screen is sharing that of the people that are here today. So thank you for filling this out. It's always wonderful to know a little bit about the composition of the people here. It looks like a nice mix. Yeah, similar to Narges, I find myself inspired. I told the team that I was going to be poring over the recordings and like writing down every word because I feel like there's a nugget of wisdom in every word. So I'm focusing today on culture and change management. And again, I have a couple stories to tell about how we've thought about implementation and doing things at NYU. And maybe some of these are ways that you can think about approaching your own deployments and integrations. So my first point is that there are forces greater than ourselves that maybe are limiting a little bit of our success. And what do I mean by that is that there's a lot of times when we know exactly what to do. So let's pose this question. There were some participants over telephone asked questions about their healthcare experiences, how to access to 2 years of medical data, and the question was, what proportion of these participants receive recommended preventative care? It ends up being like 54%, right? Recommended acute care, 54%, and recommended care for chronic conditions, 56%. So this is published in New England Journal. So even when we know what to do, like even when a machine learning model might tell us what to do, right? Like we still have other barriers to success. And I think it's important to think about what those barriers might be and how we might be able to overcome them. And so, I always open with this sort of big pictures of clinical predictive models and to say, look, at the end of the day, there's an outcome, that we're trying to assess. And Nigam kind of, did a sort of a more drilled down version of this. And I'm going to drill up a little bit and to say, look, we have our models and they can be amazing models, right? Let's say we have a model that can predict readmission like 100% of the time. But there are a couple of things that we have to do before we could realize the benefit of that model. The first thing is we have to figure out the channels, right? The notification channel. We have to figure out how people are going to get notified about this patient and what their status might be. And the next thing we have to do, if we send an email, right, might not be that efficient. If we send an alert, might be more efficient, right? As long as there are not other alerts going on. If we have a dedicated team, like in CT's example, right, then the notification efficacy might be very, very, precise. So we have to think a little bit about that. The next thing we have to do is figure out how to get the clinician or the providers to take action, right? Just because I recommend something and our machine model recommends something doesn't mean that an action will be taken. If the clinician disagrees or they see some other things going on that might explain what's happening, and so we have a little bit of action energy, right? That has to happen. And finally, there has to be some efficacy around the intervention. So, if I have an intervention that has zero efficacy, then it doesn't matter how good my model is, right? I can't actually realize the benefit on the outcome. And so when we're thinking about clinical trials and thinking about larger things, right, we have to think about all these other components, because as you kind of gather by looking at this, like you could start with a great model, but you lose signal along the way. And by the time you get to the outcome, there's nothing left. And then you don't actually see what you're hoping to see. And then you say, oh, this was just a failure. But that might not actually be true. And these other components are certainly important. So as CT pointed out, in the 80-20 rule, for us, the people are the key to success. The models are one thing, but in the notification and the action, right, those are people issues. And the grants and the stuff that my teams are focusing on are around the people issues and what's going on there and where is the value of AI in healthcare being realized. So I just want to show you the life cycle a little bit because one of the first things I'm going to talk about is how we gain trust of the users. And we have 4 pillars in how we gain trust of the users and how we kind of sort of maintain their trust. So this is probably similar to everyone. You gather data, you build a model, you do retrospective and prospective testing. One thing we do is we do something called instance emitting. So as soon as possible, we start to send examples of sort of the high scoring patients, right? High risk of readmission, high risk of dying in the next 2 months, to providers, to sort of clinician champions. Because at the end of the day, it's really hard to know what the model is doing and who is it identifying at risk until you actually start seeing those patients. And that's really important, is because once they know the patients that they're being seen, then they can start developing interventions around those patients. And that's important because when we think about establishing trust, there's kind of 4 things that we do. So one is experience, right? And to the extent that we have some clinician champions who can be consuming outputs, right, every day, looking and understanding what the model is producing, right, that helps people gain trust in the system. Data and results. So we have performance dashboards, right, that we run routinely for sensitivity and positive predictive value. Is our model working at 75% positive predictive value as we promised? And we have ways of pushing that back to people so that they know that this is working, right, and it's doing what it's supposed to do. Visualization and explanations. So in one of the papers in that COVID favorable outcome model that I talked about in the introduction, right, we have this visualization, right? It shows you what things are contributing. When people start interacting and they look at these factors, right, it can make some sense to them. They can say, oh yeah, okay, right, I see what the model's doing, right, and therefore I trust it. Which is a folly in and of itself, because there are times when people will follow models blindly. And there's some work by a colleague at Tandem that shows, like, well, if you actually give people the wrong explanations, some people will just believe the model, even if it's wrong explanations. And so we haven't delved as far yet into understanding, the value of these explanations and how much does it make people think and incorporate this into what's actually going on. And then documentation. So hopefully Mark will talk about this. So this is all his work around these model fact cards. I'll show you some examples of what we've done with our models here in terms of communication. So what's the top? So the approach number 2 is a top-down approach. And so this is what we did when we were predicting 2-month mortality. And this is the dissertation work of one of my students, Dr. Major. So the background is we built a model to predict 2-month mortality at 75% positive predictive value. And our key performance indicator was advanced care planning conversations. And so 2 months was sort of a nice sweet spot for us, because it wasn't so long that it was, well, maybe we should get something or maybe we shouldn't. But it was also short enough where, it would force a pause, right, in the team, and to sort of think, okay, are we doing everything that we need to do, to and make sure this person is getting what they want, right, in their last couple of months of life, and that it's sort of aligning, with their expectations of care. So we had 3 models that are actually running, and each model has different overlaps in the patients it identifies, so that we could get to our sort of performance metric of 50% sensitivity and 75% positive predictive value. So model 1 was a pre-admission model. So as soon as they hit the ED door, there was already data, a model calculating their prior data, right, and producing a prediction. Once they're here after the first midnight, there's another model that runs in the morning that sort of takes all the data that they were admitted with, and then runs a model on it. And then finally, there's a text classification model that runs on the H&P note and then actually tries to make a prediction as well. And this third model was interesting because, in New York, we're quite a fragmented system. So we see a lot of patients for the first time that we actually have no history on. And so we're also able to identify classes of patients who have no history at NYU who might be at risk of 2-month mortality. So the implementation was a clinical alert. You can see it here. It's outlined in a New England Journal of Medicine Catalyst paper if you want to know more. It's pretended to the attending of record and represented to each new attending. It's interruptive, and they have 1 chance to delay. And it asks if the patient's risk is appropriate and suggests a provider to consider the overall trajectory, have a documented AC conversation, and consult geriatrics or palliative care. Now, the top-down approach is this, right, is that attending that receives this alert can choose to agree or disagree, right? But then there's also a notification to the chief medical officer or whoever's overseeing that unit, who gets a second opinion. So if the person says no, they actually get a push notification, which is adhered to a second person who looks at that patient and addresses that patient as well and says, okay, do I agree or disagree with this assessment? And then if they don't, then there's there's a conversation about okay, why does this person think that's risk? Why does this person not think that's risk? And this is important because 2-month mortality is a difficult task for humans to do. If we look at the MSQ, the mandatory surprise question, and 6-month performance, it's like 50% sensitive and 50% positive predictive value when people and humans actually try to make this assessment. And so getting 2 eyes on the same alert is, certainly a good thing. And it allows some conversation about, what this patient's real risk might be. And that's why I call it top down, because, the individual providers don't necessarily have to know in the ins and out of every model that's being identified, that's being used, but the leader, right, who's receiving these, right, does need to know about the model, does need to know how it works. And through this interactive process, right, of receiving alerts, saying no, and getting an intervention, right, without attending, they're able to work through a little bit about, okay, this is what this model is doing, and then next time, right, they can incorporate that to their care. And we found this to be true because it's really hard to get everyone in the same room. When we deployed some of our models, right, and doing education, we'd get like maybe 20 or 30%, and then we'd measure later how many people actually like added this information, to their list and other things, and it just was pretty small. And so we realized that we misthought of how good our educational material was and how much action people are actually taking downstream. Right, and so this is a clinical decision alert, and we had a step where you can see another iteration there of the alert and what it looked like. So this top-down allows more than one look at the prediction. It limits having to educate a large group of people on the model and what it does. This education tends to trickle down, and it's really limited by volume of patients at risk sort of coming in. Then the third approach is the bottom-up approach. So we have a COVID-19 adverse event model. This is predicated by nursing. They had a model where they were trying to communicate with each other between shift change about how sick a patient was. And so they built this sort of rubric. They came to us and said, hey, can you help us build a better model? So we defined a task as an adverse event within 12 hours, defined by these 4 outcomes. It takes demographics, vitals, labs, auction support. And so insight one is you got to have champions. And I think this is obvious, but it's sort of something to always say is that we have our rapid response team leaders, right, who are champions in this effort and help to sort of guide the rest of the team in making this successful. We have specific directives. So here you can see a specific directive by the clinical alert team. What are their responsibilities? What's escalation expectations? How do you opt out of patient escalation? What's education plan and some notes? And so this is very important for us to be successful because we kind of assume that if you build it, people would know what to do. It's totally, completely not true. And so, we have specific guidance on how people should approach these, what they should think about, and how, they should respond or not respond. In addition, we have these model fact cards. So this is not my instantiation. This first page is very much invented by Mark Sendak and colleagues. And there's a link on the next page if you want to look more. But we added a little bit because, we wanted to be at the user level too. So we added information about what the actual visualization looks like, how to interpret the visualization, what the actual roles or responsibilities of the people are, and then what are the features. So what are the features driving the model? What are the most important features? And these are sort of continuous plots of how the odds ratios change as the numbers change, and then some Q&A. And so these are things that we package up, that we try to package up with every one of our models so people get feedback on what they see. And so, yeah, the bottom up, volume can define this bottom approach. So if you have a lot of patients, right, distributing this work is extremely helpful. In this sense, education trickles up, so it can happen at the individual level, and then people can start relying on each other to learn things. And it upgrades expertise. And so the value of these AI models here is that it can take, someone who's in nursing and sort of upgrade their experience because the model has a view of thousands of patients, right, who might have adverse events. And this helps to upgrade sort of their abilities to assess whether a patient is sick or not. And that's all I have.